With a program devoted to the therapy of thoracic trauma, recorded at the recent third postgraduate program of the Society of Thoracic Surgeons, this is Audio Digest Surgery, Volume 16, Number 5, for the week of March 12, 1969. To open this program, Baylor University's Arthur C. Bell, Jr. describes his method of managing chest trauma in the emergency room. Dr. Bell?
I thought it would be well to look at the setup we have in our emergency room, because in some instances, trauma patients are taken immediately to the operating room because it is felt by those who employ such a procedure that they have better equipment there for handling the circumstances. We've perhaps done the same thing but with a little different approach in that we have two rooms in the emergency room of our charity hospital equipped identical to an operating room. The operating room lights, the operating room table, an anesthesia machine, suction endotracheal tubes, laryngoscopes, chest bottles already set up with saline in them, ready for use. The instruments and so forth in the cabinet allow anything to be done in this particular room that can be done in the operating room. The severely traumatized patient being brought in on the ambulance stretcher is taken immediately to one of these so-called shock rooms on the ambulance stretcher and put on the operating table. The patient is disrobed completely for examination. In this way, it's possible to not miss concomitant wounds. If you try to examine the patient with the clothes on, you're occasionally going to miss a significant associated wound that'll end up killing the patient rather than the chest trauma. Sucking wounds of the chest are closed immediately by one of a variety of means. Vaseline gauze pressure dressings can be used. Temporary suture can be used. For smaller wounds, one thing that's quite helpful is the use of skin clips to temporarily close the sucking wound of the chest. In the presence of pneumothorax or hemothorax, an intercostal thoracostomy tube is inserted. We have no fear of contaminating blood in the peritoneal space by the use of a chest tube, as some people have used to argue against the use of a chest tube. The best way to prevent empyema is to obliterate the space in which the empyema will occur. In other words, you should evacuate the blood from the pleural space as quickly as possible, and in this manner you will prevent most cases of empyema. Also, the arguments used early in the first part of World War II that blood should be left in the pleural space to tamponade bleeding, I personally think is a lot of nonsense. Continued bleeding into the pleural space occurs generally from systemic vessels, such as a mammary or an intercostal. Leaving blood in will not tamponade this type of bleeding. Pulmonary parenchymal bleeding, unless it's from a major hilar vessel, generally will stop because of the low pressure system involved by expanding the lung and obliterating the space. Therefore, the most important management to us of the patient with chest trauma, with hemo and or pneumothorax, is the use of intercostal tube thoracostomy. And in most instances, it's been possible in this manner to have the patient out of the hospital in 4 to 5 days of the time of injury. The use of a chest tube requires that the tube be of adequate size. Small tubes put in through trocars almost invariably will clot and will not accomplish the desired objective. The tube should be 34 to 36 French in diameter. Our current preference is for the allo siliconized chest tubes. It should be put in the 4th or 5th intercostal space in the mid-axillary line. Lower chest tubes are fraught with danger, as they occasionally will be put into the spleen and liver, and that will produce continuing hemorrhage of the worst kind as well as considerable embarrassment to the surgeon. The diaphragm is often riding high in these people. They're grunting when you put the chest tube in, and 6 interspaced chest tubes I have seen put into the spleen by residents. So it's put in the 4th or 5th interspace. In the mid-axillary line, it serves for the evacuation of both blood and air. The mechanism of putting in the chest tube requires no complicated equipment. Trays of a special type are not necessary. The simplest expedient is to prep the area, infiltrate it, infiltrate down to the rib, and on the upper surface of the rib below. Make a nick with a knife, then use a pair of scissors or a hemostat to bluntly dissect a tract down to the pleural space. The glove finger is then inserted into the pleural space prior to the chest tube. Because there may be an unsuspected pleural synthesis in that area, and innumerable continuing air leaks have been produced by putting the chest tube into the parenchyma of the lung. So the glove finger, usually the little finger because it's a small hole for the tube, should be put in first ahead of the chest tube, then the chest tube put in with a hemostat. We generally hook the tubes to underwater seal drainage and suction to try to evacuate the blood as quickly as possible. Most patients with penetrating chest trauma will respond to this type of management. If they don't, if there's continuing hemorrhage or air leak that cannot be handled, then an operation needs to be considered. X-rays and electrocardiograms then are done as indicated. In putting in an IV, consideration is given to the possibility of a vena cava injury. And if the injury is below the diaphragm, an upper extremity vein above the diaphragm, a lower extremity vein. In general, if there's abdominal trauma, concomitantly, we will inject some radiopaque contrast media into the IV shortly before the routine X-rays. This may pick up a previously unsuspected urinary tract injury, but most importantly, it will demonstrate function of the contralateral kidney should the indication for nephrectomy present itself during operation. Should there be continuing hemorrhage, operation does not await resuscitation, but is an integral part thereof. It's just like you can turn on both faucets in the bathtub, but you'll never get the tub filled up unless you put the stopper in. And with continuing internal hemorrhage, you start blood before operation, but operation often is required before you can replace circulating blood volume. In the situation of trauma, no patient is too sick from the trauma to operate on. They're often too sick not to operate on. To review for you the results of this type of treatment in some 1,202 patients, of which the majority were males, as you might expect, a wide variety of age, and stab wounds outnumbering gunshot wounds, although in recent years the number of gunshot wounds as compared to stab wounds continues to increase. The majority of the patients were treated with intercostal tube thoracostomy. The overall mortality rate was 5.9%. The average period of hospitalization was 6.2 years, and this was increased significantly by patients with associated wounds who required long periods of hospitalization for orthopedic procedures. Other major injuries, as you would expect, the diaphragm and the liver. These major vascular injuries outside of the chest were responsible for a large percentage of the deaths. The total of 207 patients out of over 1,200 with penetrating chest trauma required thoracotomy. Laparotomy was necessary more than twice as often as thoracotomy because of either associated abdominal injuries or thoracoabdominal injuries, which usually were managed by intercostal tube thoracostomy and a separate midline laparotomy. From review of the experience in World War II, as the experience of a surgeon increased in managing chest trauma, the percentage of thoracotomies required progressively decreased. A penetrating wound to the chest is not an indication for thoracotomy. It's an indication for resuscitation and for re-expansion of the lung. Thoracotomy then is performed only for specific indications. In this particular series, immediate thoracotomies were done for two reasons. Either massive hemorrhage that was obvious at the time of admission, or for resuscitation. This means that the patient arrested as they came in the emergency room prior to any definitive treatment. Chest trauma, in my opinion, is an absolute contraindication to closed chest cardiac massage. Because if cardiac arrest has been brought about by an intrathoracic injury, the only possibility of resuscitating this patient is to concomitantly control the intrathoracic injury. As you would expect in this group, the mortality was quite high. Nevertheless, These patients all could have been pronounced DOA, and by immediate thoracotomy in the emergency room, it was possible to save a significant number of them. The most often indication for thoracotomy was of an early, delayed nature. Continuing hemorrhage, Dr. Sampson will talk about later. Recurrent pericardial tamponade, or the patient that did not respond with a heart wound to pericardiocentesis, was operated upon immediately. Clotted hemothorax of a significant degree that will compromise pulmonary function very easily is handled by an early delayed thoracotomy at 3 to 5 days, at which time all you have to do is shovel out the clots. Whereas if you wait for the time-honored 7 to 8 weeks for organization, then you're dealing with a major operative procedure, peeling off the rind, producing a lot of air leaks in the lung, and the possible complications of this. Chest wall repair, particularly from shotgun wounds at close range, was necessary in a number of patients. Loculated empyemas were handled by decortication. Persistent air leak only rarely requires thoracotomy. Esophageal injuries are a definite indication for thoracotomy and repair. On rare occasions, a late thoracotomy was required. Several intracardiac injuries, recurrent pericardial effusion requiring pericardial windows were necessary twice. Only one patient required a formal decortication for fibrothorax because of the employment of early delayed thoracotomy for significant unrelieved clotted hemothorax. Causes of death, the majority were hemorrhage of those requiring resuscitation, and operation was attempted on them rather than calling them DOA. The complications, wound infections, were somewhat high, as you might expect, but out of 1,200 and some patients, not too high. Empyema occurred in only 13 patients, and in 8 of these, there was spillage of gastrointestinal contents, usually colonic contents, into the pleural space from a thoracoabdominal stab wound. And I believe this low instance of empyema gives sufficient evidence to back the statement I made earlier that the danger of contaminating blood in the pleural space with a chest tube is not to be considered. The thing that causes empyema is a space in which it can form, and the best way to prevent it is to obliterate the space in which it can form by the use of a large enough chest tube properly placed. Our method of treating cardiac injuries. A cardiac injury to us requires no treatment if there's no evidence of tamponade, no evidence of continuing hemorrhage, although they are monitored quite closely using venous pressure as a monitor in the intensive care unit right next to the operating room. If they do show evidence of tamponade, pericardiocentesis is used as the primary method of management. If the patient does not respond immediately, or if tamponade recurs, immediate thoracotomy is performed without letting the patient arrest. If arrest should occur by any method of treatment, at any time, thoracotomy is immediately performed, whether on the ward, in the operating room, in the emergency room, or in the intensive care unit. By this method of management, all deaths of necessity fall into the operative group, and a comparison of operative versus non-operative mortality would be meaningless. Pericardiocentesis is performed usually with a 17-gauge thin-wall needle, such as is used for translumbar aortography, by the paraxiphoid route. We do not like to use the parasternal route because the left anterior descending coronary artery is directly under the inner spaces and could easily be injured. The preferred incision for cardiography, generally a left anterolateral fifth intercostal space with the right side of the chest prepped into the field, and when necessary for exposure, this is extended across the sternum into the right fourth intercostal space. The pericardial needle is left in place draining while the patient is prepared, and anesthesia is induced after prepping and draping have been performed. This allows you, if arrest occurs, to quickly go in the chest and completely relieve the pericardial tamponade. Several methods of approach to various types of heart wounds. A large heart wound in the ventricle is originally tamponaded by the finger. Retention sutures of large size are then placed in as horizontal matrices. Hemostasis finally is obtained by 3-0 running suture. Attempts to close up a large wound in the ventricle by the continuous suture, such as we can do after an open heart procedure while the pump oxygenator has the heart decompressed will generally tear out as you try to put them into the beating heart. Therefore, the mattress sutures are placed under the occluding finger and in hemostasis finally obtained with a continuous suture. Wounds of the ventricle close to a coronary artery are handled in a somewhat similar manner. They are originally tamponaded with the finger, and then horizontal mattresses are passed underneath the coronary branch and tied so as not to include the coronary. Occasionally with such an injury, a small branch of the coronary artery has been transected, and even though it's not bleeding at this time, it should be ligated, because when the blood pressure returns to normal levels, frequently in the recovery room, this will start bleeding again and necessitate reoperation. Atrial injuries are somewhat difficult to repair primarily with a continuous suture, and when possible, the atrial injury is originally tamponaded with the finger, a partial occluding clamp then used to exclude the injury, and then the injury repaired at leisure with a continuous suture. Similar to congenital defects, stab wounds and bullet wounds occasionally will produce significant fistula between the ventricles and have to be repaired as would any interventricular septal defect. Aortic injuries likewise are controlled primarily by direct finger pressure. Attempts to isolate the aorta primarily above and below the lesion usually are fraught with massive hemorrhage and death of the patient. So upon seeing the aortic injury, it's tamponaded immediately with the finger. Then the aorta is isolated and clamped above and below and definitive repair carried out. If it's not possible to apply clamps above and below, a partial occluding clamp can be placed under the tamponading finger and the wound repaired. Under certain circumstances, it's not even possible to apply a partial occluding clamp. And here the finger is used to tamponade the bleeding. Sutures are passed underneath the tamponading finger and then tied as the finger is slowly withdrawn. Blunt trauma to the chest also produces significant aortic injuries with points of fixation of the aorta at the heart, at the attachment of the ligament, and at the diaphragm. The aorta swings forward upon rapid deceleration, producing injuries at these points of attachment. These injuries can vary from an intimal tear, which may go on to obstruction, or to aneurysm formation, to a false aneurysm. It may go on to traumatic aneurysm formation, to complete transection. And although most of the patients with this type of injury will expire immediately, a significant number will survive long enough to reach it to the hospital for definitive care if the injury is recognized and repaired rapidly. The diagnosis is made by suspicion, a rapid deceleration type accident, and widening of the mediastinum on routine chest x-ray. Under these circumstances, angiography is mandatory to rule in or out an aortic injury. The technique of managing those injuries at the heart level, these usually require a graft during a period of total cardiopulmonary bypass, and I personally use coronary perfusion. The technique of managing those injuries occurring at the usual location, this is a complete transection at the area of the ligamentum arteriosum. Pump bypass from the left atrium to the femoral artery is instituted first. The intrapericardial aorta then is isolated. By getting this clamp on from within the pericardium, you stay out of the hematoma, which is often pushed all the way across the transverse arch. Once entering the hematoma, without proximal control, you might as well go get coffee, because you'll never come out of it. Therefore, the proximal aorta is approached from within the pericardium, pushing the hematoma back, remaining protected from entering the hematoma by the pericardium, and a clamp is put on the aorta between the left common carotid and the left subclavian. The aorta then is controlled distally down around the diaphragm, again staying out of the hematoma, and the left subclavian is controlled at the thoracic outlet. Once all of this has been done, the hematoma is entered, and the two ends of the aorta are staring you in the face. The clamps then can be moved to directly above and below the area of injury. Moving the lower one up is quite important in that it prevents blood loss from intercostal vessels. This usually requires a graft because of the wide distraction of the torn ends, the necessity for debridement, and the friable nature of the aorta after such an injury. An alternate technique of extracorporeal circulation for these patients is the use of partial cardiopulmonary bypass, cannulating the femoral vein and artery. If this technique is used, however, the aorta still should be approached by an intrapericardial route to get proximal control. Technique for repairing those injuries occurring at the level of the diaphragm. And we have not encountered such a lesion, but John Callahan from Canada has unfortunately had such a case. This patient had 2 transections of the aorta, and this should be kept in mind. The patient had a transection at the usual place at the ligament. Dr. Callahan repaired this lesion. The patient did well, but suddenly he died a month later. And at autopsy, the transection he had repaired and a previously unrecognized second transection at the level of the diaphragm. The method of handling these injuries is immediate operation. Extracorporeal circulation is instituted first, either pump bypass or partial cardiopulmonary bypass. Proximal and distal control is obtained, and only after the first 2 things have been done is the hematoma entered. Then definitive repair is carried out as necessary.
Thank you, Dr. Bell. Over the years, thoracotomy has come to be valued in the injured situation, but only in specific indications. In contrast to abdominal trauma, when the slightest suggestion that the abdominal wall may have been perforated is usually sufficient in itself, without any further supporting data, to go ahead with laparotomy. Now, in discussing his approaches to the operative management of chest trauma, Stanford University's Paul C. Sampson points out some of the specific indications for immediate and delayed thoracotomy. Here he is.
One could list certain non-indications which by themselves are not considered sufficient to perform a thoracotomy. First, just a large hemothorax without evidence, for instance, of shock, evidence of foreign bodies in the chest, badly contused lung, penetrating or perforating wounds by themselves, multiple fractured ribs. These are in themselves not necessarily indications for immediate thoracotomy. I want to indicate one thing in which I agree perfectly with Dr. Bell. He made a very strong point of it, and I would merely like to emphasize, and that is that in all of these patients, a sufficient time is presumably undertaken for what we call resuscitation, and that is some stabilization of blood pressure and so forth. There are, however, some situations, as he indicated, in which the operation itself becomes part of the resuscitation process. One of these, of course, is the massive severe hemorrhage, in which one has to get in and stop the hemorrhage or there will be no resuscitation. Another is a massive uncontrollable pneumothorax. Many times a patient cannot be brought into what we might call stability without surgery. A third, which we saw a great deal of in the war, rather less in civilian practice, is massive contamination of a pleural cavity, very frequently the left pleural cavity, from severe thoracoabdominal wounds. In such situations, one cannot resuscitate, in quotation marks, by the use of blood alone. Surgery is part of it. Well, to go over the specific indications, the immediate thoracotomies, continuing hemorrhage, perforating aneurysm, cardiac great vessel situations, acute pericardial tamponade, uncontrolled pneumothorax, a sucking wound, thoracoabdominal wounds, diaphragmatic hernia, esophageal perforation, which in my opinion is a very good indication for immediate thoracotomy. Mediastinal traverse, the same thing, in other words, the possibility of esophageal perforation, and finally massive clotted hemothorax. Now, when we speak of immediate hemothorax, we're talking about immediate or from an hour or two to a day or two, and within this one can speak of absolute immediate or immediate thoracotomy. Now, continued severe hemorrhage. In the case that Dr. Bell mentioned, of course, obviously the patient has a massive hemothorax, he's in shock, and there are these cases which one looks at and you just know that you have to get in there right away quick. With continuing hemorrhage, I think it takes a little more of a responsibility and a little harder to judge. There are certain guidelines that you can use, but I'd like to emphasize that no one thing tells you whether or not you should go ahead with an early or immediate thoracotomy. Some of these that we've used which seem to be suitable are those having to do with the response to blood. If there is no response to 500, 1,000, 1,500 cc's of blood, and if in the meantime there is a continuous outpouring of blood through the thoracostomy tube, then the chances are that you should get in right away. Or a blood pressure which has risen and a concomitant falling pulse, which after having risen to relatively normal limits shows a precipitous drop. Here again, I think one must consider a very early thoracotomy. If the patient resuscitates fairly well, but there is continuing amount of blood coming from the thoracostomy tube, one has to judge this. And I have seen various estimates of the amount which leads you to consider hemorrhage. I think perhaps if over several hours you have an amount of blood, say 400 or 500 cc's an hour with no signs of diminishment, then again I think one must consider hemorrhage. The usual vessels, as had been indicated, are those systemic vessels, the pulmonary hyla, heart, and so forth. How do we approach a patient who is bleeding badly? Well, you can get some lead by a missile tract if a missile is involved or a knife is involved. You can get some lead by whether you have had a severe crushing injury. And so if great vessels are involved or the heart seems to be involved, you use the type of incision as was indicated. If, however, you don't know, I think a generous posterolateral thoracoplasty, either in the 6th interspace or quickly removing the 6th rib, is about as good as you can get, and you can reach pretty much all parts of the pleural cavity through that. Now, uncontrolled pneumothorax. This is a very interesting situation. Sometimes you get it with a crush injury. This is where one has either one or two tubes in the chest under high suction, and in spite of that, you have a continuous pressure or tension pneumothorax. Call it what you will. I think this means only one thing: rupture either of the intrathoracic trachea or of the main bronchus, and I think early repair is absolutely mandatory. We have seen these people who have not been operated upon, and most of them die rather promptly. You do, if you have a tube or two tubes in the chest, have a little time, but not much. In this situation, I think not only must the windpipe be repaired meticulously, I think a routine tracheostomy is also a part of this operation.
Excuse me, Dr. Sampson, long enough to say that this, doctor, is the end of this side of your reel. On side B, Dr. Sampson continues his discussion of the operative management of chest trauma. And to hear this, simply reverse the 2 reels or cassette on your tape recorder. This is Side B, Audio Digest Surgery, Volume 16, Number 5, continuing an issue on the therapy of thoracic trauma. Now, continuing his discussion of the specific indications for immediate thoracotomy in the operative management of chest trauma, here is Dr. Paul C. Sampson.
Now, sucking wounds are an indication for at least early thoracotomy, depending on other situations. These are wounds, obviously, which suck air in and out. They can be closed temporarily while a resuscitation goes on by towel clips, skin clips, and so forth, but sooner or later they should be closed. This does not happen again very often in the civilian life. I've seen a couple of times where kids have been impaled on door handles before the door handles became so recessed now that sometimes it's even hard to open the door. War wounds, however, are a fruitful source of sucking wounds, and they made sometimes what we used to call a traumatic thoracotomy, which is the deep gutter wound across the chest at right angles to the ribs, which destroys tissue, which completely fragments 3 or 4 ribs, and sometimes the repair of these is most difficult and taxes your ingenuity. The main thing to remember is that you must do a thorough debridement, and all tissue which looks bad, which has the slightest evidence of being avascular, should be cut out. And in so doing, one then perhaps has enough tissue left to make a loose lattice work, and there are times when one can develop pedicle muscle flaps from various parts of the chest to make a tight layer. In this sort of thing, I think it is probably wise not to close the skin. One can use perhaps a few loose subcutaneous sutures, but it's perfectly all right to leave the skin open and close it as a delayed closure. Thoraco-abdominal wounds are more or less a subject in themselves. They happen in different situations. One can have a thoracic and an abdominal wound. One has to judge in deciding on your approach what is likely to be injured. Again, a muscle tract situation is good to try to decide. If you have a high thoraco-abdominal wound on the left side in which there is any chance of contamination of the pleural cavity, I personally prefer to attempt a thoraco-abdominal incision, close the diaphragm, take out feces and whatever else you may find in the left pleural cavity, get in tubes, close that, and then go ahead with whatever may be necessary immediately under the abdomen. I think in general, unless you are absolutely sure that all of your injury is high in the left upper quadrant, that what Dr. Bell suggested, a thoracic incision, if that seems to be pertinent, and then a separate abdominal incision is the thing that one should do. Now, diaphragmatic rupture may be part of a thoraco-abdominal wound, or of course, I'm sure you know, many times happens as a result of a blunt chest trauma. And very interestingly, a small amount of trauma sometimes can cause a big hole in the chest. Diaphragmatic rupture will also be mentioned a little later under delayed thoracotomies. The reason being that sometimes the hole in the diaphragm is temporarily sealed over with something, and you have no real suspicion until days or months or even years later when some, again, minor episode brings this to your attention. I think the main thing to remember is that the diaphragm should always be closed in 2 layers, and whether you do that with 1 layer and overlap or whether you do it by the imbrication method, I think makes a little difference. The right-sided diaphragmatic rupture is a little different cat sometimes, and here, of course, you practically never have early hollow viscera, and the thing that you have to worry about is the liver. Many of these, of course, are not discovered until later on. There are certain signs, however, which lead one to suspect a right-sided diaphragmatic hernia. Now, esophageal perforation, this can be done, as you know, many ways. When we're talking about injuries, we always think, of course, of penetrating or perforating wounds. But remember, the esophagus can also be injured by instrumentation, by foreign bodies, and by the so-called post-emetic or spontaneous rupture. There are certain good signs that we can use, which I think help us to decide whether or not the esophagus has been ruptured. If so, as I say, I think regardless of whether it's in the neck or in the chest, that early operation and closure is necessary. 3 signs which I think are completely diagnostic: crepitation in neck, exquisite point tenderness, and could not raise head off the pillow without supporting it with the hands. These 3 things, or I think any 2 of the 3, mean esophageal perforation. X-rays show 2 other things: much widening of the party wall, a slight catch of radio-opaque material on swallow, and something that you can't see so well, but you must always look for, and that is streaked emphysema. Now, for those patients who have thoracic perforations of the esophagus, there again are certain characteristic history that you can diagnose over the phone. And the characteristic history, of course, of the post-emetic or spontaneous rupture is that the patient eats, drinks, and was merry. He vomits, and then he has severe pain. And this, I think, is the crux of the matter. Unless this condition is considered, he is brought into the hospital either as an acute coronary because of his severe chest pain or as a ruptured ulcer. And if one continues to treat him in the coronary care unit or does a laparotomy for a ruptured ulcer, of course, the patient will die. There are several things one must look for. The main ones, the patient has a nasal twang to his voice, and this should give one the first lead. The next is that in X-ray, again, the streaky subcutaneous emphysema that you see in the mediastinum, and this accounts for the nasal twang to his voice, and also back of the heart. This sort of patient needs immediate surgery. And again, I repeat that you may not be able to resuscitate this patient without surgery. This is tremendously important. They develop a perfectly horrible mediastinitis within a matter of a few hours, and death ensues if they are not properly treated. Now, the massive clotted hemothorax that Dr. Bell referred to, I think some people do more of these cases than others. I happen to be one that am willing to give such a case a few days. I don't wait 7 weeks always to make up my mind about operating on them, but there are peculiar things about blood. We have seen repeatedly blood which has been in the pleural cavity, which was clotted, which was absolutely unaspirable by big needle, and which clogged the tube. All of a sudden, in a few days, has become liquid again, and one can delayed matter in a few days re-aspirate it. I don't think there's any question that if this clotted hemothorax remains for 4 or 5 or 6 days and you can do nothing about it, that in most centers these days a thoracotomy is relatively a safe procedure. I think there's no rush about doing it within a matter of a few days. If we can get this idea across, then I think we're all talking the same language. I think Dr. Bell may do a few more of these than I do, but again, this is a matter of what goes on in your own hometown, and the whole thing is not to dash in day one with a big chest full of blood when you may have a contused, poorly expansile lung. Give nature a chance to do things, and if you can get this patient in reasonable shape, just sit back and watch and don't be too anxious about it. Now, we'll go from this to delayed thoracotomy, and delayed thoracotomy can be anything from the few days in which we do the clotted hemothorax to a few weeks to a few months to a few years. And to start with recent discoveries, many times one has not appreciated what has happened to a chest at the time of injury, and such things as diaphragmatic hernia, aneurysms, and transections of the bronchus come up some years later. So these would have probably been operated on had they been recognized at the time of injury, but they were not. Removal of an intrathoracic foreign body, organizing hemothorax, hemothoracic empyema, And then a group of very interesting cases, rather miscellaneous, what you do with bones, ribs, and sternum in delayed procedures, chest wall hernias, and lung damage. And there are very many interesting cases of different kinds of lung damage that sometimes require delayed surgery. Now, as far as the removal of intrathoracic foreign bodies are concerned, we don't remove all of them. The latest dope I saw in an article from Vietnam is that they use roughly the same indications we did in World War II, and that is a foreign body greater than any diameter of 1.5 to 2 centimeters was taken out of hand. A .22 caliber bullet, on the other hand, that was smooth, and in the middle or peripheral part of the lung field we didn't bother. If it was very jagged, if the wound of entry had been dirty, if it was near the hilum of the lung, and particularly in the mediastinum, then it was removed whether it was causing symptoms or not. I think these are pretty standard. Again, the whole thing is that these patients get well much faster if you don't go in day one and take out that great big foreign body that's bothering everybody. Wait 10 days, 2 weeks, and again until the lung contusion has healed up and the lung is a good expansive lung. Then you can go in and take out the foreign body and the lung will expand immediately. Now, organizing hemothorax, hemothoracic empyema, there's been a fair amount written on that. I would just like to briefly review with you the fact that blood, when it clots, many times undergoes what we call organization. There's angioblastic, fibroblastic proliferation, and this, in essence, becomes an envelope in which there is a visceral pleural element and a parietal pleural element, and always somewhere along the line, this envelope turns the corner. Now, I will say that most of the time when we're operating on these things, early and fresh, we go through this into the inside of the envelope and do a true decortication. We may or may not bother with what's on the parietal pleural side. The indications for surgery are, of course, the later type of thing in which we should have operated early for a pure clotted hemothorax. I think more particularly these days, the development of infection in the hemothorax, and some of them still become infected. And I will say that an infected hemothorax, as far as I'm concerned, should be operated on relatively soon. If you are referred an empyema at a later time, then if the patient is in shape again, you operate and do a decortication and you don't drain the thing. This, I think, is the important thing, because if this is 3 or 4 weeks old and you put a tube in that, you'll never in the world get the lung out. It just will not do it because of the development of this peel or fibroblastic membrane or rind or whatever you want to call it. Now, a little additional technique to that we ordinarily employed during World War II, and that is the exenteration, the complete exenteration of these pockets, particularly when they're small. And again, this is developed on the supposition that one can get around all sides of this thing, and one can. In essence, however, we do an extrapleural separation on the chest wall side and a decortication on the lung side, and you go up and you go down and you take out this complete pocket, envelope, whatever you want to call it, without spilling the contents.
Thank you, Dr. Sampson. To conclude this week's look at the therapy of thoracic trauma, our final guest speaker, Richard M. Peters of the University of North Carolina School of Medicine at Chapel Hill, discusses some important considerations in the use of the mechanical respirator in treating chest trauma. To begin, Dr. Bell poses this question.
Dr. Peters, I'm going to ask you to elucidate the management of the patient with the flail chest, particularly with bilateral rib fractures and flail chest. Give, if you would, some specific details on exactly how you manage this patient and how you monitor both this patient and the patient on the respirator for other reasons in terms of what parameters you follow and what's the ballpark you should stay in.
First, I'd like to say something about what you're doing in an orthopedic sense when you use a respirator. This is really comparable to balanced traction when you have a fractured femur. That what you're doing is stopping there being different stresses across the fracture, which would be just like somebody trying to walk on a fractured femur. And by doing this, in a sense, you just have the elastic forces here. Now, there are certain rib fractures, just like a fracture that can happen in an extremity that you put in traction, that you can't extract the fracture with your traction, and you'll have overriding ribs that'll cut into the chest and so forth. And those are the patients who I think you ought to somehow get that rib out. Now, that isn't an emergency, an immediate thing to do, but at some point you've got to reduce this fracture reasonably like you would any other fracture. Now, when one of these patients come into the emergency room, the first thing that you always do is you get chest tubes in them, and almost invariably unless they happen to have an obliterated pleural space, they require chest tubes. We put them in these cases, in the same place as Dr. Bell would, in the posterior middle axillary line, the fourth or fifth interspace, and then if we're going to put them on a respirator, I would put another one in the second anterior interspace if they have a significant lung leak. They are intubated if they're having respiratory difficulty. Most of them, when you first see them, unless they've been really crushed between such kind of things, where there are multiple rib fractures, of a crushing injury, somebody being rolled in a roller or something like that. But the usual automobile accident with a chest tube will be reasonably well for a while. Now, if you don't have a respirator immediately available, intubate them and bag breathe them until they are resuscitated enough. Now, once you've watched them, it becomes obvious that it's hard for this patient to breathe. They're retracting, and they have paradoxical respiration. They look like they're going to get tired doing this. You've got to decide whether you're going to use a respirator or not. Now, if you wait for them to get abnormal blood gases, I think you've waited too long. You've stressed them at a time they shouldn't be stressed. So that I think it's a clinical judgment. You look at this patient, and it's obvious that he is working hard to breathe, and you can have the feeling that if this man has to keep this up, just as you see the child that retracts or something else, that he's going to wear out. At that time, I would start him on a respirator through an endotracheal tube. Now, if you've got to keep him on a respirator because he has multiple rib fractures, and if he has multiple rib fractures and a flail chest, we find it takes 2 to 3 weeks for this person to get enough stability of his chest that we want to take him out of traction. After 2 or 3 days, I would then put in a tracheostomy tube under ideal conditions in the operating room and keep him on a respirator. We monitor his blood gases and try to keep his PCO2 in the range of 35. His PO2, we don't go above 50% oxygen, and we would be satisfied with a PO2 in the range of about 85. It doesn't have to be higher than that because of the flatness of the upper part of the oxygen dissociation curve.
What about if his PO2 is down to, say, 45 on the 50% oxygen? Would you increase your oxygen content?
I don't believe it'll do you much good, because at that point it's a shunt and you don't gain very much by increasing your oxygen content. It's at that point that I would try to hyperexpand his lungs or put a respiratory retard in.
More pressure.
Yes, and keep his end tidal pressure up, adding the resistance.
Well, you're monitoring his arterial and venous pressure. You're monitoring his pH, PCO2, and PO2. Mm-hmm. Is there further monitoring you would do to manage this patient?
When I say we're monitoring his arterial pressure, I don't mean that you've got to have an intra-arterial catheter. You're going to be taking it every 5 minutes. If you can do an intra-arterial catheter, fine, but these, and the venous pressure at intervals. No, I think it would be nice in these kind of patients also to monitor their EKG, because some of them get respiratory alkalosis, and they can get ventricular arrhythmias then, and you may want to treat them with some potassium or slow your respirator down. But these then become the niceties that you add on if you have all these facilities. But I don't think they are absolutely necessary to safely treat these patients.
What about humidity in the respirator? Do you get adequate humidity from the commonly available respirators?
My opinion is that in most you get too much. I remind you that water vapor is invisible, and that if you see a fine mist coming out, you're not getting water vapor, you're getting a fog. And in most cases, it's worse than a Los Angeles smog. It's a bacterial smog. Plus the fact you're pumping a lot of water into these patients, and this water is quickly absorbed by the tracheobronchial tree. And you want to be very cautious about pumping this much water into a patient through his trachea. So I would say, in our experience, we've been satisfied with the humidification systems. For instance, the Emerson ventilator or the Bennett ventilator. You don't need more than this, and if you see a mist coming out, turn the humidifier down. Now, the real danger here is infection, and if you use one of these humidifiers, make sure that it's changed every day, or if it can't be changed, that it's rinsed out with acetic acid every 24 hours, and then get the acetic acid out of it if you can. But make sure that you don't use them for a week or 10 days at a time. On all of our ventilators, we require that all of the tubing from the ventilator to the patient be changed every 24 hours and new tubing used. And this comes to your complications. There are very serious complications of infection. If you make these patients alkalotic, you can get the serious complications of cardiac arrhythmias, and all that goes with respiratory alkalosis, convulsions in some of these patients. So that to use a respirator means that you undertake a difficult type of therapy. And I think this is some justification for perhaps the more conservative methods, but my experience in a serious crushed chest in the attempt to use wires and towel clips is that I'm very glad to have another means at this time.
Well, how about the cases in between that are not to the serious stage, but the patient is paradoxing some, which is giving them more trouble with secretions? When would you use the towel clip in the sternum for the costochondral separation, bilateral separations, or maybe Hudson's traction with Steinman pins under the pectoralis muscles? When should you use the more minor things?
I would prefer respirators if I'm going that far. I think that many patients have some paradoxical respiration, which if you keep them sucked out, keep them with adequate sedation so they can cough and so forth, do not require a respirator or any of these other things. Everybody who has 2 broken ribs does not have to have a respirator. And another aspect of this is that a young, healthy person who has mechanically normal lungs at the time of injury can withstand a pretty considerable damage to his chest wall and get well himself. An older person who has mechanically deranged lungs, who already has wide swings in pressure just to breathe before he was injured, will need a respirator at a much lesser degree of injury.
In regard to the type of respirator, volume cycled versus pressure cycled, and specific makes of respirators, do you still prefer the Emerson? Dr. Peters?
We at present use the Emerson ventilator, I guess because we think it has the best price advantage, although as you all know now, Bennett and others have come out with very good volume cycled respirators, some of them more versatile. I think that pressure cycled respirators in this type of patient are usually fraught with considerable limitations, and that they aren't very useful for this. If you do use a pressure cycled respirator, and I think with any type of respirator, you should have some method of measuring the expired tidal volume so you can make sure you're delivering the tidal volume you think you ought to. Because even the volume cycled respirators all have leaks in their valving and their tubing, and when you set them to deliver a certain amount, there's no assurance that they do. With a little experience we've had with a new Bennett respirator, which is not a pressure cycle, but their new volume respirator, it does deliver fairly near to its rated volume. One other thing that you have to remember is if the pressure goes up and you're required to deliver air at a high pressure, then there is compression of air within the respirator, and all of them have a large amount of air compressed within them. And even measuring the expired tidal volume, you will not be measuring actually what came out of the patient. You'll be measuring what came out of the patient and the amount that the gas within the respirator can expand. And if you're using 50 centimeters of water, this is a significant amount. In all respirators, one of the big limiting factors is their valving mechanisms. The other thing that I like is a respirator that's simple to operate because it's very easy to do things incorrectly. I think that the Emerson ventilator fits the fact that it's simple to operate. You don't have to have a PhD to run the thing. The new Bennett respirator, though it has a great many controls, has them very clearly labeled and is apparently very easy to use when you first use it. The pressure cycled respirators, I think the best explanation I have from this is one of our medical chest men was told that all you had to do was to know how to talk to a bird respirator and you could make it work for this, and his only answer was that he didn't know bird talk. The pressure cycled respirator for a patient with mechanical abnormalities of the chest is a priority going to be difficult for you to operate because mechanical abnormalities are going to require increasing pressures or changing pressures to get tidal volume. And it, after all, is tidal volume which tells whether the patient is adequately ventilated. I think it's very important to realize that the respirator manufacturers are recognizing these problems and are trying to meet them. Now, if you use a pressure cycled respirator in patients with respiratory abnormalities, you must not drive it with oxygen. If the only source of pressure you have is oxygen, you are bound to get too high an oxygen concentration and you will have oxygen toxicity. If you drive it with compressed air, you must make sure that it's medical compressed air. If you have an oil compressor giving you your compressed air, which is what you have in most laboratories, there are fine oil droplets in this air, and you can give these patients lipoid pneumonia if they have a prolonged period of respiration. So you have to insist that they be driven with medical compressed air.
Dr. Peters, question on the instance of tracheal complications following respirator management more than 5 days. This refers to the use of the cuff tubes and pressure in association with the cuff tubes.
Well, we feel pretty strongly in our institution that you shouldn't use metal tubes in this situation any longer. You have to remember, if you're driving a respirator at this pressure, that tube, and if you watch those tubes, they're driven into the patient every time this occurs. And so that I don't think you ought to use metal tubes. We use silastic tubes, knowing that their lumen is smaller and knowing that we don't have an inside tube to take out. We blow the bag up, we let it down for 10 minutes out of every hour. This leads to some leaks, and I'm sure that it isn't exactly done. As you all know, the difficulties of getting this kind of thing is done in a busy intensive care unit. The complications, so far, we have not had any late strictures that we've recognized. Now, whether we would have noticed some narrowing of many of these trachea if we had actually done bronchial studies, I don't know. I would refer you to Dr. Hermes Grillo's articles about this. I think he's done the best work on it and has shown really very frightening ulceration and beating up of the tracheal cartilages with serious stenoses. I think the important thing here is to have your tracheostomy tube positioned fairly high and to have a rubber tube and to try and fix it reasonably well. The other way to protect your patient on the respirator is have a short piece of quite flexible tubing between the respirator outlet and the connection to the trachea, so that a good deal of the shock force of the respirator driving is absorbed by this tubing. You then will not drive the tube into the trachea quite so much. You're all aware that with a low tracheostomy or too long a tube, you can actually erode through the trachea into the vessels, and the most common vessel to have this happen to is the carotid artery. And in my experience, this has been almost a universally fatal complication because it isn't recognized early and you have a direct connection between the carotid artery and the trachea. The other important consideration is tracheal care. And infection is very dangerous. When you have a tracheostomy in or an endotracheal tube, you have all of the fantastic protection that's given by the upper airway to infection. And after trying many things, we've come to insist that all these patients have a catheter used once and then have it discarded, and that the nurses, when they do this, wear sterile gloves. Now, this is expensive, but it's not nearly as expensive as the infections you get, and we try to train people so they don't touch the end of the catheter, and they'll do it this way. But when we really get down to saying they have to put on sterile gloves, they realize the true feeling that we have about the sterility of this technique, and this in itself puts it at the right level of importance, and nothing else has worked in our institution anyway.
Dick, you mentioned earlier that you insist on changing the tubing on the respirator every day and use new tubing. I assume by that you mean that the tubing is re-sterilized and not brand new tubing, because our controller would shoot us if we did that. How do you go about handling that tubing?
It's just washed, and then it's gas sterilized with ethylene oxide and then allowed to air out enough to get rid of that. And what it amounts to is, and there is some expense in this, it means you've got to have for each respirator about 3 sets of tubing.
This is a problem in the airing out of it, and you find that your purchasing agent is going to say, well, 2 is adequate because you can have one while you're sterilizing the other, and it doesn't allow adequate aeration after gas sterilization.
No, it really takes 3, you're right, and in the long run, it isn't a great additional expense to the hospital because the real wear is on the ward. We haven't been impressed that they deteriorate much faster when they've been cleaned this way.
Thank you, Dr. Peters. And this concludes this edition of Audio Digest Surgery, produced twice each month by the Audio Digest Foundation as a non-profit subsidiary of the California Medical Association. All rights are reserved.